want to keep their videos off, totally fine, not a problem. Thank you all for joining today. My name is Natalie Olias. I work with the Contra Costa Family Justice Center. You are hopefully in the right room. This is for our Family Justice Institute series. And today we are going to be talking about the dangers of strangulation. This training is really geared towards direct service providers, medical facility personnel, anything in that realm. But we will have this posted to our Family Justice Center YouTube page after the presentation. So you're welcome to share that out with your colleagues, clients, whoever you think might need this information. Let me go ahead and start sharing my screen here. And I want to introduce our presenters for today. So Dr. Watson, do you want to go first?
Sure. Would you like me to introduce myself, Natalie?
Yes, that would be great.
Fantastic. Well, good afternoon, everyone. I'm Carrie Watson. I am a practicing OBGYN physician at Kaiser Permanente. My office is in the Antioch area, and I have some additional training in medical strangulation and happy to be here to talk with all of you. Thanks for having me.
Thank you. And Ashley.
Hi all, I'm Ashley Palomino. I'm the Intervention Support Services Manager. That's an old title.
Sorry.
Same basic thing. It's okay. I oversee the crisis line, which includes our LAP program, our lethality assessment protocol, as well as the community advocates that are at FJCs and EHSDs.
Thank you. All right. Well, I'm going to go ahead and let Dr. Watson get us going here.
Thanks. And Natalie, can you tell me a little bit, just remind me what our time frame is so I can be respectful of our time?
Sure. We have about an hour for the whole presentation today.
Okay. Fantastic. Well, if you don't mind going back just one slide, I'd love to help us center before we start talking about such a heavy topic. So I always like to talk or begin this discussion with some centering. So to do that, we're going to take a series of deep breaths. And what I invite you to do while you're taking some deep breaths is to think about why you're here, what brought you here, and hopefully there's some piece that's hopeful in that you'll just take a moment to meditate on as we take a few deep breaths. So we'll take a deep breath in and out. And then another deep breath in, just remembering why we're here and the hope that we have that brings us here. And then one last deep breath in and out. So the content we're going to discuss today is heavy. It's about intimate partner violence, strangulation, and can be triggering, can be uncomfortable. So I encourage you from the get-go to take care of yourself. Hold on to that piece of hope and let it take you throughout the conversation. And if at any point it's a little bit much, I encourage you to step away and come back. There will be some images, but I will give a disclosure before we get there. So let's go ahead to the next slide then. The information I'm going to share with you is from the Family Justice Center network, from the Strangulation Institute, and they started their work based on these two tragic deaths that happened really close together in 1995, Cassandra Stewart and Tamara Smith, both women who were murdered by their partner. As you can see, they were both mothers of young children. And one of the things that was really striking to the district attorney at the time was that both of these women had significant experiences of strangulation, either right before or as part of their murder. And so it caused her to ask this really crucial question: what if strangulation was a significant warning sign? It was something that had been really largely overlooked by many people who interact with people experiencing violence, such as law enforcement, medical professionals, DV advocacy. But Gail Strack, who was the district attorney at the time in San Diego, asked, man, what if strangulation is different and we're totally minimizing it? And this sort of set her and some other colleagues on a course to learn a lot more. So we really want to honor both Cassandra and Tamara's memory. And hopefully we can learn from their experience and do better for our patients and clients. Let's go ahead to the next slide. This is the place where you can find the information that will follow. So if you have more questions, there's a really robust resource here. So great to take a look at. We'll go to the next slide. So first of all, understanding what strangulation is really valuable. Your client or patient may say that they've been choked, but what they usually mean is that they've been strangled. The difference is choking is where food gets caught in the tube between the mouth and the stomach. It's called, it's supposed to go down that tube, but it actually gets caught in the trachea, the windpipe. When food gets stuck there, it obstructs breathing. Maybe you've seen this happen in a restaurant where someone's, sort of stands up and says, oh, the person I'm with can't breathe. And then they need the Heimlich maneuver or something to help get that out of their airway so that they can breathe. That's what choking is. Strangulation is different. Strangulation is pressure that's been applied to another person's neck. And it can obstruct airway, but more significantly, and what usually causes more of the symptoms, is that it also obstructs the large vessels, the blood vessels that are in the neck. And that's what causes the symptoms that people feel. Let's go ahead to the next slide. So strangulation is that constant pressure applied to the neck. It can happen in a number of different ways. Most of the time in the setting of intimate partner violence strangulation, it's happening with hands. So that means manual strangulation. There are other ways that a partner can strangle their partner, either with a ligature, can happen by hanging. And then people can't even use other objects, being smothered, for instance, with a pillow or with other objects has a similar outcome to strangulation. And again, this may be referred to by your client or patient as choking or suffocating, or they may just simply say, I don't know what happened, but I couldn't breathe and I blacked out. So we'll talk about some of those phrases that are really key that will kind of cue you to ask more questions about strangulation. Let's go to the next slide. So this is a very busy medical textbook type image. Don't let it intimidate you here. What I want to show is that underneath these blood vessels, underneath the muscles, so on the left side of this diagram, you see a lot of these sort of like rusty colored muscles. That's sort of what's most towards the surface in the neck. Underneath them, which you see on the right, are the large blood vessels. The red vessel is what's depicted as taking blood from the heart to the brain with oxygen. And then the blue vessel is sort of how we traditionally depict deoxygenated blood that's coming back from the brain to the heart. So they're huge blood vessels. They're obviously very important because they're managing the oxygen supply to the brain. And they are relatively close to the surface because they're just underneath those muscles, right? So they do have some protection, but they're relatively close to the surface. And that's why they can be so easily impacted. When those become obstructed, you can imagine if there's pressure applied, it actually does not take a lot of pressure to obstruct the venous blood flow, the deoxygenated blood that's leaving the brain. And it sounds like that wouldn't be as big of a deal because it's not the blood with the oxygen, but that if you think about plumbing in your home or something, right? Every part of the plumbing has to work in order for it to be functional. So the same thing is true of getting oxygen to and from the brain. If one part of the pathway is not functional, then immediately there's going to be consequences in terms of oxygen delivery and uptake in the brain. So obstruction of that venous outflow, that sort of blue vessel, can cause loss of consciousness relatively quickly, even within minutes. Once that happens, loss of consciousness makes our muscles really what they call flaccid or weak. And then that allows further pressure to obstruct that lower or deeper carotid artery that's taking oxygenated blood to the brain. One other thing that can happen is that the carotid sinus, which is a bundle of nerves that are also kind of right in this area. They're harder to see in this picture, but the carotid sinus can be stimulated by a lot of pressure or by rubbing, and that also reduces heart rate. So the effect of these three things: obstruction of the venous outflow from the brain, obstruction of the arterial inflow to the brain, and then potential stimulation of the carotid sinus, all of this can have huge impact for reducing the amount of oxygen that's getting to the brain. That's sort of the bottom line here, and that's what's causing harm. Next slide. So strangulation can be fatal very rapidly. Loss of consciousness can happen, depending on how much pressure is there, can happen within just a few seconds, 10 to 20 seconds. Or if there's lighter pressure, it can take longer for loss of consciousness to happen. But with intense pressure, you can have permanent brain damage very rapidly within even a few minutes. It doesn't take more than maybe 4 or 5 minutes to cause death when there's a lot of pressure being applied. So strangulation should always be thought of as very high risk for serious injury, as well as for fatality, right? Strangulation can be fatal. Next slide. Now, strangulation has its own risks, as we talked about, right? It can cause serious medical injury, it can cause death, and it is associated with a lot of other serious health outcomes. Now, a lot of the strangulation data is related to female victims with a male perpetrator. A lot of this is, a lot of the original data intentionally looked at female victims. So the data I'm going to share with you and that follows is quite gendered. And we know that strangulation can happen in any kind of relationship with any kind of perpetrator. So it's important to keep that in mind and not sort of lose focus or have too much bias that strangulation only happens in certain kinds of relationships. So there's that offers a bit of an explanation about the gendered data that will follow. Almost 90% of women who were strangled by their partner had a prior DV history with them. Many of them, in fact, most of them, were threatened with being murdered when this happened. Most of them thought they would die when the abuse was happening. And these perpetrators are a bit unique in the sense that they often have a criminal history. As we talked about, this can be fatal. And we also know from this data that Gail Strack and others have put together is that half the time kids are present. So this is a really horrendous act that can have significant consequences. And it's not the kind of thing that typically happens at the beginning of an abusive relationship, but is often part of escalating violence with a pretty dangerous perpetrator. Next slide. To add to that, the data shows that when a survivor has been strangled, they experience both increased in their risk of attempted homicide in the future, as well as their risk of successful homicide. And these numbers are pretty astounding, right? That's a very dramatic increase in their risk. So anytime you hear a patient or a client discuss something that sounds like strangulation, it's always worth learning more, to offer help and support for the strangulation itself, but also to really think about lethality assessment and safety planning, because these are clients and patients who are really at high risk of ongoing injury or murder. Let's go ahead to the next slide. This is one of the really big challenges about strangulation. If we don't ask, it's really hard to know if it's happened. In about half of patients that were studied in this original 300-person cohort, 50% of the patients had no visible injury at all. In this group here, they were sort of broke it down into another group that's sort of represented by the blue people. That was about 35% who had a visible injury, but it was so small it couldn't even be photographed. And then visible injury is present really just a small fraction of the time. So we can't rely on visible injury to guide us. Let's go ahead to the next slide. So in the medical field, we think about signs and symptoms that help lead to a diagnosis of what's actually happened. And this is helpful for you, no matter really where you are intersecting with patients and clients, because you may have to do a little bit of detective work, thinking through like what happened to this patient. They may not be able to tell you exactly what happened. So some signs or symptoms that should sort of raise your curiosity about this would be reporting throat pain, reporting voice changes. Maybe the patient's having some difficulty in breathing. Maybe they're having pain with swallowing, or swallowing isn't happening as easily. They've described some loss of consciousness or seizure-like activity. If they've had ear pain or headache. If they're breathing really rapidly, we call that hyperventilation. And then maybe they've had an accident. Maybe they've lost control of their bladder or bowel. And perhaps you may not know this, except that a patient may say, oh, I've changed my clothes. So it's important to figure out why, right? People can be quite embarrassed about this. It's understandable. But this is really helpful information about what happened. And then like those physical injuries that we may not see, we also may not have symptoms reported from our patients immediately after strangulation. You know, one of the things that happens in the body is that when there's trauma, it can take some time for inflammation and swelling to show up. And so we may not see these kinds of symptoms right away because swelling has to happen in order to cause some of these things. And then, of course, patients who've lost consciousness may just not remember what happened, and that can make this challenging. Next slide, please. So as we discussed, you may not see any visible injury at all. So we can't use visible injury alone as a guide for strangulation. And if there is a visible injury, it may take some time to show, again, because inflammation takes time to develop. Some of the things that you could see would include cuts or finger-shaped imprints on the neck. I do have some pictures of these later. You may also see some bruising. Usually this is under the jaw, or it can be behind the ears. You may see sort of bruising with a particular shape, like a thumb or a finger, or if there's a ligature, you may see a line. You may also see what we call excoriations. These are scratch marks. These can be inflicted by the patient in self-defense. And that can be really telling, especially if you see a combination of, say, finger-shaped bruising and excoriations. This is where the client is, you know, sort of reaching up and trying to get a perpetrator's hands off of their neck. And then again, you know, visible injuries may be quite subtle. So you may not be able to document them with a photograph. This is where it's helpful to describe them in writing. Another thing that's helpful to look at is petechiae. These are little red dots that you may see in the eyes, in the white part of the eyes, or sometimes in the face or the ears. On autopsy, they can be seen on internal organs. I think the easiest place to see them on a living survivor is in the white part of the eyes, or what we call the pharynx, which is the upper inside part of the mouth. All of these things, well, particularly the petechiae and the excoriations, you know, they can be present from other causes. So none of these things necessarily guarantee strangulation, although certainly, you know, finger-shaped bruising is very suspicious. But when you put it all together with a patient's story, you can start to sort of get a sense of what actually happened. Next slide. Some of the serious risks that can happen with strangulation are what we call carotid dissection. So you remember that blood vessel that's going up through the neck to the brain with the oxygenated blood. This can start to split, which it sounds like it's a big deal. It is a big deal. This can happen in about 1 to 2% of strangulation assaults. One of the other things that can happen is an injury to the vertebrae. Those are the bones in the spine across the neck. So the total incidence of a serious injury like this, we think, is about 2%. Truly, I wish there was a lot more data on this so we could know for sure. 2% sounds small, but the significance is that if one of these things has happened, it can be seriously life-threatening. So it's really important to evaluate for these in cases of strangulation. Other things that may take time to be able to recognize include stroke or traumatic brain injury, and these can also happen in the setting of strangulation. Let's head to the next slide. This is a study from 2017 from a hospital that conducted about 400 strangulation exams, and they found a rate of adverse outcomes that was a little bit higher than that 2% number. So this is more recent data, which is why I'm sharing it here. They found 2 carotid artery dissections, 2 fractures of the hyoid bone. There is this bone kind of right here behind the chin that can but does not always become fractured with strangulation. Edema is swelling of the tissue, and sometimes this can be so significant it can obstruct breathing. So they found 3 cases of that. They found 2 herniated discs in the spine, and then a variety of other, pretty significant impacts, such as miscarriage, symptoms of stroke, enlargement of lymph nodes. Pleural effusion means getting fluid in the lungs. Also vertebral fracture, which we've talked about, and then other issues related to the carotid artery that were different than a dissection. One of the things we can sometimes see with a dissection is that injured area of the artery becomes a point where the blood coagulates and can build a clot, and then that can go to the brain and cause a stroke. So all of these things are pretty serious. And again, a 5% risk may sound low, but 5% risk of something serious happening is worth evaluating. Let's go ahead to the next slide. This is the strangulation protocol. It actually may be a slightly outdated version, but the newer version does look very much like this. And you can find that newest version through the Strangulation Institute or perhaps your local family justice center. This is very helpful for medical practitioners to sort of think through which patients need more evaluation and which patients are safe to go home with strict precautions. So you'll see that side on the right, patients who don't have any of those little red spots in their eyes, those petechia that we talked about, patients that don't have any obvious soft tissue damage to the neck, they're not having trouble breathing or speaking or swallowing, and they also don't have any signs of like seizures or mental status changes. So those kinds of patients who can, watch themselves at home or have someone who can help watch them at home are typically safe for discharge with precautions. And then the other side, the left side of this, is really all the patients where it's recommended to have some sort of further evaluation. It's listed here that the gold standard is a CT. This is typically what's recommended. I do think we probably need a little bit more data to be able to say with confidence that it's the true gold standard, but this really is what we understand as the best way to evaluate, particularly the carotid arteries and the vertebral arteries. Let's go ahead to the next slide. Many experts recommend observation of these patients for 12 or 24 hours. This can be in the hospital, particularly in the cases that I mentioned here, where there's loss of consciousness, they have those petechiae, soft tissue injury, or if the patient, had an accident and may have urinated on themselves or defecated, or if the patient's intoxicated or just really cannot evaluate themselves at home. Those are all situations where it may be beneficial to evaluate them in the hospital. This is an example of a young patient who was seen in our setting, actually, who came in with some neck bruising and pain. Initially, said, oh, there's no strangulation involved. This patient did happen to have some obvious signs of this, bruising on the neck, some tenderness, pain on movement of the neck, and the physician was concerned enough that they recommended further evaluation, and the patient then explained that she had been assaulted, and the police were already involved. She ended up having a CT that did show a dissection of her artery. The treatment is actually aspirin, which is a very mild blood thinner, and it does just enough to help prevent that clot formation, to help protect people from stroke. So it sounds like a really small intervention, and yet it may have been life-saving for this very young patient who unfortunately declined some other services. So this is an example of how this can be quite helpful. Next slide. This is another example on imaging. If you're not used to looking at CT images, no problem. I can explain this to you. So this is a picture, kind of imagine like a line through someone's head, and you're sort of looking at from the back towards the front. The white parts at the top are the bony structures of the skull. And then in the middle, where the arrows are pointing, it's always helpful to have arrows on your radiology pictures, are areas where the blood vessels are quite narrow and obstructed. This is also a young patient who had been strangled, and she ended up having bilateral arterial dissections, which is even more significant because it means both sides, like 100% of the, or nearly 100% of the blood flow going to her brain with oxygen was nearly obstructed. So this could really have been very dangerous and possibly fatal for this young patient. And it wasn't identified immediately after, it was actually identified a few days later. So I think it's worth remembering that even patients who have not been evaluated in the first 12 or 24 hours after strangulation, they may still have benefit from being evaluated in a medical setting, even several days after assault. There is not consensus on how long after an assault imaging should be done. I know there are like 1 or 2 experts who even recommend 6 or 12 months. I've talked with some of the experts in my institution. They usually recommend they would not do imaging really past 6 months. But 6 months is still a huge window to consider imaging for patients like this. Next slide. All right, so here's your trigger warning. There are going to be some images of real survivors with some of the bruising and excoriations that I've talked about. So if this is not for you, now's your moment to step away. Let's go ahead to the next slide. So this is an example of what abrasions under the chin can look like. What sometimes happens in these situations is that patients will put their chin down, kind of like I'm doing now, but they'll do it so fast and with so much force because they're fearful that they can actually cause, it's like a self-inflicted bruise from moving their chin away. So that's something you may see. Next slide. These are excoriations or scratch marks, right? And these also may be self-inflicted if a patient's trying to get a perpetrator's hand off of their neck. Next slide. This is an image of that bruising behind the ear, and you can imagine a perpetrator, reaching for the neck and having some hands kind of up high behind the ear, as well as like on the neck, with a lot of force to cause that bruising. So it's helpful to lift up the hair and do an exam to check behind there and take photos if you're able. Next slide. This is another example of that thumbprint bruising. Apologies for the quality of this photo, but the bruising could really be anywhere on the neck, but I'd be very curious in a patient like this to look at the other side, because you may see fingerprints on the other side to sort of go along with it. Next slide. This is, it sort of looks like excoriations, but if you look closely, there's sort of the bright red marks, and then there's the more faint and not well demarcated, lighter sort of pink lines that extend from it. These are actually finger impressions, and we can see sort of 3 decently well. I wish I had a pointer here to show you. But we can see 3 here decently well, which often is what happens because the pressure in the pinky finger just is not as strong. So often if I'm, ooh, thank you so much. Yes, Natalie. The pressure in the pinky finger is not as strong. So if you're going to see finger marks, you'll often see 3 instead of 4. That's pretty common. Yeah, exactly. Let's go to that next slide. This is a list of some other resources, as well as at the bottom, the website for the Strangulation Training Institute. Again, they have very extensive resources and a more updated version of that medical guidance. Thank you so much.
Thank you, Dr. Watson. I want to give folks a chance to ask Dr. Watson any questions that they might have before we continue on with our presentation. And feel free to put it in the chat or come off of mute, whatever you're more comfortable with. And we'll also do questions at the end as well, if that's easier. Okay, I'm not hearing anything, so we'll keep going forward. And like I said, we'll do questions again, and then we'll also give out contact information if something comes up when you're meeting with a client or a patient that you want to ask. We're happy to be in contact about that. So I'm going to talk a little bit about why knowing about strangulation matters. I think all of you that are signed up for this training are aware that strangulation is really important and can be lethal, especially in domestic violence situations, sexual assault situations. We also have even seen cases of strangulation in human trafficking situations. So it sort of runs the gamut, but it is an indicator of non-fatal strangulation, and that is an indicator of a potential lethal case. So why it matters, I mean, really is because regardless of what field you work in, you may at some point run into somebody who has been strangled, choked, had their airway blocked in some way, maybe by a pillow or, you know, anything like that. The most important thing is when that person discloses to you, we want you to be able to be equipped and comfortable in knowing what the next steps are. And if your organization doesn't really have a protocol around this, I'm going to go into sharing about the protocol that we created. And that really was based off of a law that was passed several years ago now. This was prior to COVID. It was California SB 40. And what it required was that law enforcement was now supposed to, in responding to DV calls, it was supposed to give an advisement or a warning in those calls. If somebody had mentioned that they were strangled or it was a DV situation and the victim had, you know, if they had any visible injuries, law enforcement was then supposed to tell them something about the dangers of strangulation. And that's literally all that the legislature did. They said, okay, this law has been passed. Now all of the California counties get to go and figure out how to do that. So you're like, okay, great. So Contra Costa County created its own strangulation task force in 2019. And this really, I have to give a lot of credit to Dr. Carrie Watson, because she was sort of the main person who had gone to a training at the Strangulation Institute, and then this bill was passed, said, we have to have this in Contra Costa County. This is life-threatening for several individuals. And so the Strangulation Task Force was created among law enforcement agencies, community-based organizations like our Domestic Violence Crisis Center, our Family Justice Center. The DA's office was present. Our county offices, which is Employment and Human Services Department, was present. And then, as you can see, several law enforcement agencies. Kaiser was also present. We've had John Muir come on board as well, because we want to make sure that anywhere that a victim might go to get help for strangulation or for a domestic violence situation, we want them to get the same information. And so part of what the Strangulation Task Force in Contra Costa County did was we needed to create the language for what law enforcement was going to have to say. And I give this as a caveat because in Contra Costa County, there are 26 law enforcement agencies. And so getting them to do anything uniformly is really hard, really hard. And so we created this strangulation advisement card, and this was based off of the advisement card samples that they have on the Strangulation Training Institute website. We modified it a little bit, but you can see in these quotes right here this is what the law enforcement officer carries with them in their patrol car when they go to a DV scene and strangulation is mentioned, choking is mentioned, anything of that. They actually have to now read, as a law enforcement officer, I have a duty to warn you, et cetera, et cetera. But we wanted to make sure that a couple of the things that, because victims are going to be getting this information, we wanted them to know the signs that they should look out for of any severe injuries or symptoms they might be aware of. So this was really critical for us to give the information to the victim in an immediate response way. And on the back of the card, oh, excuse me, This part right here is a law enforcement officer, and I have the duty to warn you, that's just this blown up a little bit. On the back of the card, it actually tells if somebody goes to a hospital, it actually tells the doctors, nurses, these are the scans that need to happen. And so this way, a victim who is, they might be suffering from vocal changes, they might have a headache, they might feel nauseous, anything like that. We've taken the onus off of the victim to know what to say to the medical personnel and for them just to know what to do. And so this is utilized by the 26 law enforcement agencies in Contra Costa County. It is also utilized by the Family Justice Center, by STAND for Families Free of Violence, which is the Domestic Violence Crisis Center. And we want this to be very aware and apparent and very clear that regardless of whether you're going to the hospital, whether you're going to talk to a hotline worker over STAND's line, that this is the same information that you're going to be getting. So I'm going to talk just briefly about the Family Justice Center protocol, and then I'm going to hand it over to Ashley to go a little more in depth. But basically what happens is if a client comes in and one of our advocates is meeting with one of them, and it's mentioned that they were choked, that their airway was blocked in some way, that they lost consciousness for a little bit, or they blacked out, everything else in that conversation stops. And it now becomes, do we have a life-threatening injury in this person that we need to have taken care of right away? And so we assess the timeline. We ask, how long ago did this happen? How many times did it happen? Have you been to the hospital or seen by a doctor already? Would you be interested in having that happen? So even as that statistic from a couple of slides ago said, even though that individual patient that came in to Kaiser facility had been strangled 6 days ago, there was still an injury that took place that was life-threatening for that person. And so even if it's been a week, 2 weeks out, if somebody's still having a hoarse voice, or they're really like a foggy head kind of thing, we're still going to try and get them as much as possible to go to a hospital, because we want them to get checked out if they haven't been already. And then we immediately connect them to STAND, Families Free of Violence, because STAND does a more extensive danger assessment with that client. And they also then do safety planning with that client. And if need be, they can get that client into shelter. So every situation is different, but we want to make sure that those connections all happen immediately after the medical, is sort of taken care of and looked after. And I'm going to turn it over to Ashley now to talk a little bit more about the danger assessment that STAND does.
Yeah, thank you. So we have what's called our LAP program, LAP, Lethality Assessment Protocol Program. So this is based off of some evidence from Maryland Network Against Domestic Violence. They wanted to see, is domestic violence homicide preventable? How can we prevent this? How can we get rid of this, right? What can we do about this? And so in their review of domestic violence homicides, they were able to compare risk factors in those cases to Jackie Campbell's danger assessment, which is also very well researched and evidence-based as well. And this research was done with Jackie Campbell. And they found 11 key questions from the danger assessment that were present in all of the domestic violence homicides. So again, someone who's killed by their intimate partner. Based on the number of percentages, they organized a screening tool to kind of, again, screen folks at the highest risk of being killed. One of the biggest key factors at that time was 90%, around 90% of those who had been killed by their partner thought that they were going to be killed by their partner. And that was the only risk factor that was known at the time. Right. Again, there's probably more going on, but that was what we knew based on the research, based on the interviews from the families, community members, and access that was received by the clients. In addition to that, they also found a huge discrepancy in terms of who was seeking services from domestic violence agencies. And they found that 96% of those who had been killed in the Maryland research had not contacted an agency like STAND, a domestic violence agency for services. However, about 50% of them had some interaction with law enforcement. So huge gap between STAND essentially seeing only 4% and law enforcement seeing 50%. So how do we bridge that? And so what they did is they got these key questions, these 11 questions, and partnered with law enforcement to give them a screening tool to screen these folks in to see who is at risk of being killed by their partner. With just having that tool, and folks who are screened at the highest risk of being killed by their partner would immediately get connected to an advocate. So it's a differentiated response. So they're immediately connected, and the goal is to get them into services within the first 48 hours from that incident. Knowing that, again, victims have the right to choose, and they are not calling the police to get into STAND services or domestic violence agency services. They're calling to stop the violence. They're calling to be safe, right? And so there's only about 20% actually come into services across the nation. But again, those who came into services or got connected or even just talked to an advocate on the scene with those officers, they found that not only were they safe, was there a decrease of homicide rate by about 50%. So they decreased the homicide rate. And those who even were not at high risk of homicide were less likely to be in a future relationship that was also violent, right? So all around, the key was a differentiated response and active access, on the scene access to an advocate, really through the hotline or coming directly into shelter. And so back in 2015, Maryland Network reached out to a number of different agencies and selected 4 across the nation. STAN was one of those, to pilot this project to see, can we replicate those results? Can we also decrease the homicide rate here in Contra Costa County? And so we were able to pilot that with 3 law enforcement jurisdictions. And we currently are past that demonstration initiative and the research period, and we are still working with 4 law enforcement. Again, we have 26, so not all of them are doing the same protocol. But again, those law enforcement, when they go out to scene, after their investigation, after they do their questionings, they then do the lap screening. And if those victims are at the highest risk of being killed by their partner, they then are immediately contacted. We have a specific designated lap line for those officers to call and try and connect with the victims or provide follow-up calls, right? Again, knowing that the victims may not want to come into services, but should they want to come into services, should they need that service, they can actually be dropped off at our shelter here at the door, and we will direct them into the room. We have spaces reserved for those clients because, again, it's a differentiated response. So there's no screenings, there's nothing around that. It's immediately getting them into services. That's the goal. And I think, is there any, I think the stats are, oh no, so this is the last screening. This is actually a dated version. This is the version we currently use in our county. I will say that because of the research on strangulation, they have actually updated the lap screening to include the question, have you ever been choked by the person, into the top scoring question. And so the way that this screening tool works is that there's 2 different sections. So it's either automatically because they answer enough questions and they could just answer 1 in that top section, or 4 in the bottom section, or there's a gut response, right? That the officer or even the advocate, because again, advocates also do the screening tool on the hotline, in the community. When we meet with folks, we hear red flags, we do the screening tool as well. And so there's a couple different ways to screen in. Then we go into safety planning and going into those details, especially if they say that they have been choked, right? Again, if you ask a client, have you ever been strangled? They will tell you no. But they might say, oh, you know, the person had their hands around my throat, or, you know, I don't really know what happened. I was on the floor 1 second, or, you know, I was so scared, I peed myself. Those are signs that more than likely you were strangled to near consciousness, to becoming unconscious, and potentially almost death, right? Losing bodily functioning. And so those are the key questions that we really go into immediate safety planning. Again, just like FJC, what's the immediate medical need? Can we get you connected? Can we call telehealth? Are you open to going to see a doctor? You know, explaining that they are managed reporting, which is also, we're in a, you know, a shift too, is if around if the doctors do report to the police, not all folks are wanting to talk to police or feel safe enough to report that to police. But explaining that just because they're safe now does not mean that they're not going to have any symptoms later, and they could potentially die after the incident happened. And that's the thing that the community doesn't understand, is you can be safe after, physically maybe not have symptoms, and something could still happen, right? You could still have a stroke. You could still have internal injuries that you cannot see. You may not have bruising, you know, especially depending on the pigmentation of your skin, right? We saw those pictures where lighter colored folks. You have darker skin, you're probably not going to see any bruising, right? And so those are things to really be mindful of around what the client needs, and how do we connect them to get some sort of medical intervention just to make sure that they're safe. And a lot of times, again, these folks, if they are wanting to come into services, may not want to go to the hospital until they know that they have a safe place over their head, right? And coming into shelter. So great, come into shelter, let's get you settled. Now, can we now take you to the hospital, right? And transport you there to make sure, again, are you physically safe? Are you okay? Because that's our concern. In addition to that, we also refer folks into a high-risk MDT. So we have the whole Contra Costa County. Any member on that team can nominate a case who's at high risk of homicide, whether through the lap screening or through FJCs, or police departments can also nominate these cases to really wrap around, in particular when there is that choking question. Yeah. And I think, do I have stats here in strangulation? Yes. So because, again, our lap screening does have you ever been choked? Again, mimicking the language that clients are more likely to answer honestly from their perspective and understand the question. We have some data, right? So the shift of having advocates even just have these conversations and knowledge around strangulation really shifted when we got the lap screening. And from our data, from 2015 through 2019, 60% of all of the victims, so that's not high danger, answered yes to choking. Huge, right? And you can see the breakdown between, 2019, 60% answered yes, 57% answered yes. So it really stays within that 60%, higher 50s, lower 60s%. And again, this is all lap screenings. This is not just those who are at the highest risk of being killed. And so again, because of this research, because Maryland continues to look at this tool, that's one of the main reasons why they shifted that choking question from a secondary screening factor to a primary screening factor, because that means all of these clients would have been high danger. So 60% of all of our laps, if we had moved that question up, would be automatically at high risk of being killed by their partner, which, as we know, you're 700 times more likely to be killed, or 700% more likely to be killed by your partner if there's choking involved, right? So it matches the data. And because we have this data, that's why we prioritize strangulation, because it is one of those things that, again, gets minimized because it doesn't take very much pressure, right? People think it's like the movies where you really have to squeeze. It's not, though. It's not, and it's minimized in a lot of different ways. And it's really having these deeper level conversations around what it actually is and how dangerous it really is. And again, if strangulation was used in one incident, it's more likely to recur. And the more times it recurs, the more likely you are to be killed. And we really try to safety plan and work with folks around how do they stay safe.
All right, thank you, Ashley, and thank you, Dr. Watson. I want to give time for questions if folks have them. I'm going to go ahead and stop sharing the screen, but what I will let you know is that, as I said, the slides will be available for folks. We'll send those out in an email, and then we'll also have this training up on our YouTube page. Give us a couple hours, or like tomorrow morning. But you're welcome to share that. We encourage sharing of this information, and really sort of our ask at the end of each of these presentations, Dr. Watson, Ashley, and I have been doing for several years now because of the Strangulation Task Force. We want you to actively tell your colleagues about what you learned today, because the more people that know this information, the more likely you might be able to save somebody's life that comes in saying, I have throat pain. I'm feeling really hoarse. I think I was choked. I'm not sure. If you can recognize that right away, that may be the difference between them getting medical help right away or them not going back to a dangerous situation. We don't know the possibilities, but the only way we know is that if everybody else can give that information. Questions that folks have. I know it's a little bit of a quieter group.
Hi, I'm sorry. I don't know if I missed this, but you said that you had a protocol. Was that just the sheet where you go through and ask them the questions, or is there something else in addition to that?
Yeah, so our protocol's a little bit, so Family Justice Center's protocol is a little bit different than Stan's. And then in the hospitals, they have their own protocol if somebody discloses that they've been strangled or they're in an abusive relationship. So each one of them kind of differs. So the protocol for the Family Justice Center, if somebody discloses that information, is for us to get them ask medical questions first. Have you been seen by a doctor? Do you need some support? And then to connect them with a stand advocate that can do more of the safety planning, can do the danger assessment. And I know that Kaiser has a protocol of rooming alone patients. So if a patient just schedules an appointment, with their primary care physician, they go into that room by themselves and then are asked questions around their safety within the home. And depending on those responses, if those responses are yes, they may be connected to other resources like a social worker, or they may need to get screening right away if they disclose that they have been strangled to some capacity. Carrie, Dr. Watson, did I answer that correctly?
Yes, that's accurate. Yeah, we're really working hard to try to screen everybody. I wish it was universal. It's not, but we're working on that.
Thank you.
Yeah, absolutely. Other questions from folks? All right. Well, I can't thank you enough for being here today. I know this topic is sometimes hard to discuss, but it is a very important topic. And, as we're at the end of beginning of November, we just ended Domestic Violence Awareness Month. We wanted to make sure to have one of these trainings this year. We felt it was really important to do that, and we're so grateful that you all stayed on with us to get this information. So again, feel free to reach out with any questions, and we'll follow up with the materials so that you have that at your fingertips. All right, have a good rest of your day, everybody.